Good afternoon, everyone. I'll try again without the mute on. My name is Sally Lewis. I'm the National Clinical Lead for Value-Based Healthcare in Wales, and today I'm joined with an illustrious panel of guests to talk about a really important topic. In recent years, we've seen an exponential growth in interest in the use of better digital communication with patients to support their care, and as a result, data inputted by patients for improving their care, for example, in the monitoring of chronic illness or for quality improvement of services. However, real-time access to data, including patient-generated data, is beset with technical problems, as well as issues of trust and information governance. And we must address all of these issues if we're to benefit patients fully with this technology. So our panel of experts today will discuss the journey towards making this data accessible to those who need it to support care, covering work spanning from the legal and ethical frameworks to support access and use of the data to the technical advances required to be able to store, link and manipulate the data to make NHS Wales a data-informed, value-driven system that is responsive to what matters to its citizens. And the first of my panelists today is going to address the question of patient-facing technology and digital communication with patients. Stephen Frith has a very long history in health informatics. He is extremely experienced, has 30 years experience in this field, and he is currently the Programme Director for the Digital Services for Patients and Public programme. In this role, Stephen needs to balance the innovation and progress that can be unleashed with open health data on one hand, against the equally fundamental needs of data integrity and protection of personal data for individuals on the other. Stephen also has a passion for sailing, classic cars and wine, which is severely hampered by his DIY house renovation project, but I don't suppose we'll have time to talk about that today. Over to you, Stephen.
Hi, thanks very much, Sally. I like to think I'm not old enough to have 30 years experience in health informatics, but I guess reality says a different story. I'll keep it very brief because I've just got 5 minutes to run through the programme. And DSPP is a programme. It's an enabling programme to support the capture of data to support care delivery. So that's quite an interesting distinction. A lot of people will be talking about how the data that's captured can be used to support care. I'm talking about the processes of capturing that data and having an improved interaction with members of the public and patients through transformational technology. And I won't go into the details of the DSP programme on the call today, but we are running fortnightly briefings, so do reach out and get in touch if you've not heard about the DSPP programme in detail. But I did want to focus on the areas where DSPP can help with the capture of data to support the use of patient-generated data in care delivery. So just moving to the first slide. And this is a kind of a slide that people have seen before, really, where the NHS data is traditionally in silos to support operational service delivery. So nothing wrong with that. It works. We've got systems like PAS systems, radiology systems, pathology systems, etc. Big systems that support complex day-to-day operations and work well. Then there's been a kind of a second evolution, if you like, of that, where we've put data warehousing and slices of data in to support service design and clinical service delivery and to support research. And we're also pretty good at taking those data warehouse slices out of these legacy systems. But I think there's a kind of third step in the evolution that we're on at the moment, which is to take that data as a slice and put it in front of patients and the public. And that's really what the DSPP programme is about, and making that a two-way interaction. But actually the whole model then spins on its head. And if we move to the next slide and we think about what it means in terms of putting members of the public in the middle and using digital services, which are typically exemplified by an application on a mobile device, the number of interactions that can be facilitated through that device and direct communication with patients and the public are huge. And you know, the size of the landscape really can't be overstated when you put the patient in the middle. And that means a number of things that have impacted on the way that the programme has been set up in Wales to take this forwards. The first is that it's got to be distributed delivery with lots of people working on their various aspects of it, but in a kind of coordinated framework. We've got to share the effort of moving to improved direct communication with patients in a bilateral way, with information flowing out and in. And that it also means, secondly, that the programme has to be an enabling platform. It's not a programme that delivers everything. It's a programme that takes some of the common themes and delivers those as a set of services. Things such as moving data out in a secure fashion, moving data back in, which is what we're talking about today, and getting the data from members of the public in a coordinated fashion. But it means authenticating the individuals and having a common approach to identity management to remove one of the big barriers of sharing data, and a consistent security model over the top of that. And it means a consistent set of rules and information governance rule books that present both the legal requirements and the best practice requirements for doing this. So that's the kind of environment in which DSPP has been established, to set up a range of core services that allow others to kind of build out and plug and play onto the core platform services. And in particular, looking at secure movement of data in and out. But a third way to look at it is, when you consider it from the patient perspective, is to think of it from in terms of putting all of the information in a kind of a data vault for the individual, and it's a kind of conceptual data vault where all the data is stored. We know that it's distributed across the multiple systems, and it's never actually in one place physically, but for most people, considering that data to be stored in one single data vault for their benefit is a useful way of communicating with them and describing the experience. And so the DSPP programme is as much about creating that illusion of a single data vault for an individual as it is about joining up the technology and programmes behind the scenes. And then the final part of the jigsaw is putting information governance over the top of that, and others on this panel will talk more about that. But if we just move on to the next slide and talk about the kind of the benefits of doing this. I mean, they broadly fall into two groups from my perspective. There's the benefit in terms of the increasingly documented knowledge that people that are actively involved in their care through direct communication and influence in the design of their care plans, they get better outcomes. People are more engaged, take more care, and the outcomes improve. But secondly, we can do different delivery models, better models of care, more appropriate models of care, and the bottom line is that means that the money goes further. We spend the money on the right things. So they're the benefits of doing this, and creating a much more dynamic communication with patients and the public. And that's about all I was going to say. I've got one more slide, I think, that just describes the kind of technical ecosystem that supports the plug and play, and there's many components to it. But largely it's about creating a centre of excellence where everybody working in patient-facing digital services can come together, share best practice, make use of common underlying services like identity management and preference models and demographic information, and then build out on the patient interface, using appropriate and innovative models of both care and digital service delivery, but all working on a common platform and creating a cohesive patient experience. So that's really where I see DSPP as a programme facilitating in this space and supporting as much the capture of patient data and storage of patient data in a consistent fashion as it is about the use of that data. So I'll stop there and hand over to the next speaker. Thank you.
Thanks, Stephen. And that's really interesting, and I think you'll agree really important that we build that ecosystem, particularly in relation to work we're doing in value-based healthcare around PROMs, around patient-reported outcome measures, And delegates that will have listened to presentations from Kerry Bygrave and Mohi Khan earlier today will recognise straight away the importance of this in terms of allowing PROMs to inform care and improve outcomes for patients in many clinical areas. And that's just one benefit that we can derive from this technological approach. So thank you for that. I now want to turn to Rachel Powell. Rachel is Deputy Director of Information at Digital Health and Care Wales. Rachel actually has an amazingly diverse experience across the whole system of the NHS, spanning finance, strategic planning, informatics and information governance. And it's that sort of boundary spanning leadership that is really key, I think, to unblocking some of the wicked problems that we've got with in the system. Rachel also leads for Value in Health on behalf of Digital Health and Care Wales on informatics as part of our Global Innovation Hub status with the World Economic Forum. Rachel, it's really great to have you on the panel, and you're going to talk to us, I know, about the importance of information and our strategic approach to that. Thank you.
Thank you, Sally, and afternoon, everyone. So as Sally said in introduction, I'm Rachel Powell, Deputy Director of Information at DHCW. And I've been asked to give a brief overview of the strategic approach to and importance of information. So if I can show the next slide, please. I actually wanted to start by giving quite an honest overview of some of the challenges that our information colleagues face. And this visual summarises that position pretty well. We've seen some fantastic data products as part of the Value in Health programme, with thanks to my team. And the focus on specific clinical areas such as lung cancer and heart failure. And I know that the team are working really hard to constantly improve and expand the information that we make available as part of this programme. However, what I wanted to highlight is that the insights, reporting and dashboards are only part of the process. And actually the time, effort and skill required to create and maintain a well-curated store of data is what's often overlooked. Within DHCW Data Warehouse, we hold over 30 years worth of healthcare data sets, and the data flows really do vary considerably in terms of frequency, size, volume and structure. So the strategic approach to information is really focusing on how we can improve data quality at source, including patient-generated data, which Stephen touched on earlier, bringing that data into a secure environment where it can be curated and linked with other data sets, and then through robust governance models, make this information accessible to those who have a legitimate right to access. The outputs of various insights and data products, which we all like to see, will in turn then help us to work towards a value-driven system that's truly data-informed and is responsive to what matters to its citizens. And this is what our teams want to focus more on, to be honest, if we can truly sort the iceberg under the water's surface. And I won't steal my colleague's thunder because we'll hear more on the approach in terms of information governance from Darren, who will touch on the governance approach that we're working on, and also George, our Assistant Chief Infrastructure Architect, on how the NDR is working towards the plan for developing a national data platform. So next slide, please. I did want to briefly touch upon, however, one of DHCW's strategic objectives, value from data, to emphasise the importance of data and information and to describe how it's central to the work of the organisation. There isn't time, unfortunately, to describe how data features across all of the programmes, although for those who are really interested, where IMTP does a pretty good job at articulating it. There are several examples which I can highlight where a focus on data and information is contributing to the overarching aim of driving value for data for better patient outcomes and service planning. So we're COVID Data Store and Data Hub, which is sought to bring together key data sets into one area in order to provide information for critical decision making and service planning throughout the pandemic. We're Primary Care Information Portal, supporting general practices, clusters, health boards and Welsh Government with patient level and aggregated data and information for direct patient care and service planning. National data sets for community care to provide insight on delivery and monitor demand in areas such as rehab services, district nursing, looked after children and mental health. And of course, Value in Health, where our focus has been bringing data from a wide range of data sources, providing insights on efficiency and outcomes for a range of specific clinical areas. So I think there's little I need to add to say about the importance of information. And if there's any positives to be taken from the last 18 months, it's around the recognition that data and information is received and its central role in organising the limited resources we have for effective service planning and direct patient care with a focus on patient outcomes. Our thirst for acquiring more data, including patient-generated data, and linking this with other data sets is central to a strategic approach, which will in turn directly improve healthcare across NHS Wales. Thank you.
Thank you, Rachel. I mean, it's really fascinating to me because I know that when I started to get involved with informatics, I massively underestimated the amount of work that currently has to go on just to acquire and clean data. So, you know, we can't underestimate that, and the need also to improve on that. I totally agree.
Thank you.
I now want to turn to Darren Lloyd. Darren is the Head of Information Governance at Digital Health and Care Wales. And Darren has been working exclusively within information governance for the last 20 years and is a font of all knowledge on IG in Wales. The role of health and social care to demonstrate compliance within areas of information security, confidentiality and privacy has grown significantly with the advent of electronic systems, and Darren has been helping to deliver the strategy of providing more comprehensive access to patient information to a wider set of professionals responsible for delivering health and social care within Wales. But that strategy obviously needs to be balanced with the need to ensure that the confidentiality of those records is maintained for any new systems and services that come online or are yet to be devised. So Darren, can I turn to you now to talk to us about the information governance aspects and indeed the ethics of this, please?
Yep. Thank you very much, Sally, and good afternoon to everybody who's on the call today. If I could go to my first slide. As Sally said, I have experience in terms of understanding some of the challenges that come about as a result of meeting both the services and the patient's expectations in terms of confidentiality and privacy. Of course, we make a high availability of information. So we try and make information as highly available as possible in terms of the point of care for the patient, and also available for those that are stakeholders within that sort of patient journey and need to improve services. But that high availability, of course, is set against the requirements of that privacy and confidentiality need. So it could be said that I do lose sleep quite often in terms of trying to balance those things collectively together, because they are a great challenge. The expectations of individuals in order to ensure that their information is kept private and confidential under the auspices of health and care and wider than that into public services, of course, is a real big challenge. So data protection and privacy law have always had those dual objectives of facilitating free flowing of information and protecting the individual's interest in privacy and preventing inappropriate use of that data. So it's a great challenge, and something where, as Sally has alluded to, is that the role of an information governance professional or the discipline of information governance has grown exponentially over the last 5 to 10 years. The need to have that fast flow and availability of data whilst meeting those requirements. So data protection is being thought about as ensuring a full range of individual interests to make sure they be considered while enabling that sort of growth through the data. Data is becoming more readily available because of electronic means and by technology, but to meet the pace of that change, then we have to meet the pace of the governance arrangements that actually come with that, and that's quite, that is a fundamental challenge. If I can have the next slide, please. So we do have we probably have more than a two-dimensional problem, but in terms of these slides, the dimensional problem there is, as I've said, the sheer volume of information flows and the uses of health and social care data are beyond the ability and expectations for individuals to micromanage, and actually for regulators to easily enforce as well. So that sheer volume of information that is available to use, the days where you would normally put individuals in front of some elements of decision making at a very micro level are very, very difficult to actually achieve. You have to put systems and services in that and technologies that will help support that decision making, but providing those areas of assurance that come with that, so that individuals can be assured that that information is kept safe and secure in different ways. So information is presented in multiple ways using diverse set of technologies and systems, and we move from something that's described as direct care and indirect care uses quite regularly. So those where information is used hands-on, and those where that information is used in order to make service improvements, those type of things. So there are a number of different use cases and differences within the system where we need to use data on a regular basis. And of course, the rapid access to that data is key to make agile decision making. It's no good having that data within a 2 or 5 year cycle in order to make decisions that have to be absolutely rapid because of certain circumstances. And Rachel alluded to that. One key element of that, of course, was COVID, in terms of trying to make some rapid decisions on basis of data that was coming through almost on a minute by minute basis. Live data is immediate from reporting. Is now immediate from reporting to in the form of dashboards. So where information is now being made available for clinical treatment and care, it can now be made available so that is there for reporting as well. But it's really important to understand what the controls are in those mechanisms, so that organisations are not inadvertently disclosing information without those controls. So a governance model and a framework is required to anticipate a very diverse set of data use cases, and that's really important. If I could have the other slide. So this is kind of just I suppose, a pictorial representation of some of those things that need to be in that control mechanism. It had to have that sort of that framework. So you have your inputs and you have your controls, and then you have your outputs. But those controls have a set of requirements to set around it, whether they be regulatory. Of course, it isn't just elements of data protection. We do have regulation, of course. We have to follow some very clear codes that are set by our Commissioner, the Information Commissioner's Office. We also, of course, have the legislation then, things like the Data Protection Act, the General Data Protection Regulations, Control of Patient Information Regulations, and other NHS codes of confidentiality. And to be honest, I could go on. There are lots of rules and regulations that we have to understand in order to make sure that these mechanisms are in place. So it is a very complex picture. Again, Rachel's example was really good in terms of that iceberg. The control mechanisms are as complicated as those things that we need in terms of the data and the data requirements in terms of the integrity. So to put those down as a set of foundations are really, really important to assure that from a transparency perspective, patients and the public can be assured that that information is being used correctly. Last slide, if possible. So the benefits are pretty obvious to me, is that there's an accountability element to it. We create safe domains where use of information is assured. It's more relevant as well, so it's relevant for individuals to understand what those controls are, and we are transparent about making that control relevant as well. And those systems are clear, those standards are clear, so that all stakeholders are fully aware of what their role and responsibility is when they are actually requiring information or need access to data. And to have some freedom to innovate as well, because data is there. We need to have some freedom and flexibility to innovate with the data, but also have those controls at the same time. So that was a quick run through in terms of what is a very complex area, I would suggest, but the things that we do consider on a very regular basis while we're designing systems and services where data is inherent in that design.
Thank you very much, Darren. And I think we're really starting to build up a picture now of just the sheer amount of work that needs to go into us safely and effectively using data, and especially patient-generated data, I guess, from a strategic point of view, from an information governance point of view, from a digital communication with patients point of view. And I now want to turn to the final sort of piece of the jigsaw puzzle in this, because obviously if we're going to access data for all of these purposes in a timely fashion, there needs to be a structure to that data, a technical structure to that data and data standards. And that is why in Wales we are creating the National Data Resource. So I'd like to introduce my last guest now, George Olney. Hi, George. George is the Assistant Chief Architect for the National Data Resource and is jointly responsible for leading on the technical strategy for the NDR and delivering the platform that will underpin the effective use of health and social care data in Wales. George came into the programme in March 2020, and obviously during the pandemic we were all redeployed, and George spent a lot of time designing the national contact tracing system, which we were using in Wales. He's been a technical design architect for many years and really advocates aligning the business requirement to the technical solution, which is absolutely what we're talking about today. So really looking forward to hearing what you have to say, George.
Thank you very much, Sally. Good afternoon, everybody. So I'm a last-minute replacement into this mix today. So my slides may be the slides may not follow what I'm going to say here, but I'm going to talk about the NDR briefly, and to say really that we've got the NDR is responsible for that platform, that data platform, and I guess we've got two aims really. One is that we're tasked with opening up the architecture. So this is about giving access to existing operational data and doing it in such a way that it's secure, using kind of open standards. And as well as that real-time operational data, we're tasked with building this national data analytical data platform, and also with building a data science platform. In terms of the program, so there's a lot of technical people on the program, and it's a federated model as well. We have product specialists that sit at that sit at health boards, and they act as our conduit into the requirements of the health boards, and look at how we're going to federate data from health boards and how we're going to get data to health boards as well. I think. This diagram just shows all the exciting things in the data sphere. Can we move on to the next slide, please? And again, really, I think a lot of the benefits you will be well rehearsed as to the point of bringing all this data together and having this national platform where this data is joined and can be used for a variety of things. You know, our vision is for this to become like the National Library of Wales, but the national data platform for Wales, where all that data is and can be joined up and do some really exciting things with it. Now, I'm a technical person, so I'm going to move on to my third slide, because this is the one that I'll be drawing on the most here, really. So I've talked. So apologies if you've just had a heavy lunch. I'll try and keep this quite simple. So as I said, we've got our aims are to build this liberated operational data platform. And on the left-hand side of our diagram here, all our data at the moment, our real-time data, is held in a DHCW data center, and that data is moved around the systems using this product called Fiorano. This messaging system has been used for some time now, and one of the main issues, I suppose, with the operational data is that it's mostly presented through the Welsh Clinical Portal, which is great, but there's a requirement to actually access those back-end W data sets directly. So from the operational side, our task really is to present that data in a very useful way, I suppose. And I think there are two ways that we're looking to do this. Number one, for health boards that want that data in the short term, we're looking to provide that data via Fiorano and push that data to people that wish to subscribe to it. So instead of going to the results reporting service, our Welsh results reporting service is populated by pathology and radiology systems. So what we're advocating is, in the short term, if there are health boards that wish to take that data from the pathology systems and the radiology systems, then we would push that via Fiorano in the same way as we update our national results platform. But going forward, on the right hand side, there's these big 4 letters, FIRE. So for us, really, the future for the operational piece is to start sharing that data that sits behind the portal at the moment in an open way. So FIRE is an open standard, and it allows you to put your clinical data in there. So people can, if they understand FIRE, they can go and pick that data. They can pick that data up effectively and easily within that platform. And our focus there is on things like diagnostics, demographics, a number of other areas as well. And the NDR program is tasked with opening up that architecture and providing access to that operational data. And we are doing that via API management, which sits the left of that diagram. So we've been in the process of procuring an API manager, which looks after the security, the audit, and the control of access to that back-end data. This is a short to long-term project. Some of the data, our existing data sets in our proprietary systems, we're going to put a FIRE front end on those without redeveloping them. And going forward, we will look to migrate them into a native FIRE platform. Now, sitting underneath that, so that's the operational data, and then sitting underneath that we're going to build a national data lakehouse. So a lakehouse is something that is like a warehouse, but it's on acid, I suppose, because it can take data at speed as well as in batches. And our aims in this area are to build an electronic catalogue of data with very, very strong stewardship there, replace manual technologies we've got at the moment, and hold the who's providing the data, who's using the data, what are the governance modules, the lineage, the provenance, the linkage of that data. We're looking at building this national lakehouse for that, and also creating a team that manage the security of that and the publication of those data sets, whether that's by using de-identification, or whether that's by looking at data loss prevention techniques that stop data going out to the wrong people, or giving people the right access to that data based on policies that we have. And then underneath that lakehouse then is that with that FIRE stuff, with the lakehouse, underneath we want to build a managed data science platform. So I say managed in the sense that we want to use a system that's already been set up, where we can just start doing the data science piece and take the richness of the data that comes from the lakehouse and our FIRE store, and combine that with the algorithms, data science algorithms allow us to do things like predictive analytics and more clever stuff than that. And I've just put some examples about DICOM, being able to do predictive analytics on DICOM images, and also read clinical notes and code them with SNOMED codes. And then just a couple of things on the left-hand side before I finish then. So just from the left-hand side at the moment, from the top bit, I talked a little bit about how we do integration at the moment. With any systems that DHCW use going forward for application development will need to federate their data into this new FIRE repository that we're going to be building. We're in a conversation with health boards about what this local CDR and what the data warehouse looks like in health boards, and what data we will federate into the centre, what data will be consumed from the centre, and what data goes back from the centre. And then similarly, in terms of other organisations, all those will be inputs into the centre as well. And we'll look at ways of how how that data is joined together and then consumed back from that piece as well. And then finally, just speaking about DSPP, so the work for DSPP for the patient is effectively going to be powered by the National Data Resource Platform through that API. So, and on top there, you know, everybody's telephone, everybody's iPhone speaks FHIR at the moment, so you can send your health data via FHIR at the moment for your iPhone. So, you know, one of the things it could push your FHIR data through API management to our national FHIR store. But really, that the platform on the right-hand side is what we are tasked with building and supporting for all this good work.
Gosh, thanks, George. And I mean, I think, you know, that slide shows, you know, the enormous potential that if we can get this right, we can really start to use data to improve outcomes for patients and really change the way we deliver services, doing that in a much more efficient way, using our technology. Huge potential, but of course, still some quite big barriers. And there are some really you know, quite profound questions coming through in the chat that I'm going to weave into some of the questions that I had for the panel. And the first one really is about, unsurprisingly, I guess, information governance, and more than that, trust and confidence of patients and clinicians, indeed, in the work that we're doing here. So the first question is this. Some of our projects ideally require data to tie up between primary care as well as health board or secondary care data. And bringing that data together is so challenging and time consuming that we often put it into the too difficult box. Would the panel like to comment on these challenges, and would they comment on the pace of IAG legislation as to whether that's keeping up with the current landscape? And I suppose wider than that, how do we build trust and confidence in patients and the public around the legitimate use of their data, because many of them, of course, would absolutely support the use of their data to improve care, to improve advances in cancer therapies, for example. So how do we build trust there, and how do we build trust in primary care as well? Can I come to you first, Darren?
Yep, certainly. Thanks, Sally. I think just to take on that point of trust to start with, I think building trust in how we use the data requires complete transparency, but more importantly, a willingness to take the time to tell people what is happening, both the stakeholders and the patients. I think we don't do that well. We have to take more time in order to try and explain the situation that we're trying to build to. Some programs do put a lot of emphasis on that. It isn't that, you know, but I think sometimes we forget how much work is required in order to do that, because that trust element is absolutely key to trying to achieve what we want to do collectively. Sometimes we just plough forwards without taking the time to tell people what we're trying to achieve in certain areas. We hit sort of that silo mentality sometimes, and it's really important that we have to take everybody with us, because once there's a level of understanding, then there is far more support. I think there is that sort of one significant area where public confidence could be increased, because what we also do is convey what those robust access rules are for everyone, and the implications for any organisation or any individual found to be taking data out of context or using it beyond their responsibility and power, so it comes both ways. The other thing is about having honest and open conversations on how data is used to support care. It's very important. I think the public and people still largely trust the likes of the NHS and wider public services sort of with the data that's held about them. However, there's still a lot of ambiguity, and there's misinformation about it's used, how it's used and controlled. So aspects like patient confidentiality is maintained, so that people have that assurance that we're still working it hard in the background to maintain that balance. And I think just coming back to some of the other elements in terms of the question, said the pace of IG legislation. I think there is a lot of learning from COVID. Rachel mentioned it earlier. I think we can remove certain barriers, legislative barriers, in order to achieve that, but there has to be an acceptance of that. you have to be able to allow certain things to happen in the first phase in order to get to an outcome that you need. That trust has to be built first, and COVID has seen that there's certain regulations that we've been able to set aside in the COVID response, in the COVID pandemic response, in order to achieve some outcomes that had to be achieved quickly in order to respond to the pandemic. And I think we have to look at those, and I know there are a lot of government initiatives currently looking at some of those rules and regulations to see where we can actually allow things to happen more freely and more quickly, but try and ensure that those controls are still maintained as well. So it's about having open and honest conversations and being completely transparent about those things as well.
Yes, thank you, Darren. And I want to bring Rachel in now as well on that. And Rachel, can you expand on that? And could you also perhaps comment on another question that's come in related to this, which is around variation in interpretation of information governance guidance, because I guess that reflects the complexity of the landscape sometimes. How might we address some of these issues?
So yeah, just to echo Darren's points really, but to add something else. So fully supportive of what Darren's just said, but one of the things that we're constantly trying to improve, but also make sure that we've got really robust governance processes in place. Clearly, we're in a very privileged position within DHCW and my information team where we can access a lot of different information sources, and we are in a unique position where we link that together, but we spend an awful lot of time actually securing that information, making sure that only the right people see it when they need to. You know, we've got a very close relationship with SAIL as well in Swansea University, where we've got some really clever pseudonymization techniques, and we've worked with SAIL for a number of years. And as I say, the governance as well, and we work closely with colleagues within GPC Wales, etc. So we are seeing, and I mentioned it in my presentation, there's a real thirst for information and a requirement to, we get it, and we know that the importance of making that information available, and through the NDR programme in particular, we're working to make that accessible and available to those who need to see it. But I think building on the governance approach as well, that's something that we've been taking really seriously, and we want to build on those relationships and that trust that we've got in place to progress that even further. The other thing I wanted to mention was around our responsibility. Since we became a special health authority, DHCW, on the 1st of April, we've also become a stats producing body in our own right now, and there's actually an onus on us to be publishing more data. So historically, we process and curate a lot of information and pack it back, send it back to the health board, send it back to GP practices, Welsh Government, Public Health Wales, but we do little or limited in terms of publishing data sets ourselves off our own back. I think there's actually a big onus on where we can move more into that arena and make the information readily available. And actually through my information team, we see a lot of information requests coming directly into us, so we can start to monitor where the information requirements are, and actually we can be a little bit ahead of the curve in the future and start to publish that more, so it's readily available and accessible. So definitely one to look out for. But I think there was a question in the bar about an assessment and really understanding what data we've got available, what data sets, what data flows, and we have a lot of that already, but doing a lot more work in that area to really benchmark what we've got and what we could do more of in terms of making that more available and publishable.
Thanks, Rachel, and thanks for weaving in that point as well, because that was on my radar too, so thank you for that. My next question is for George. There's a few questions coming through here of a similar theme. A constant challenge in using data, including in existing national data sets, is understanding exactly what has been recorded and how. Data standards only go so far, as in practice there will always be relevant and often justifiable variation in how data is produced and the context in which that happens. How will the NDR project support collaborative documentation of data sets and their contents?
So I'll kind of go back to the slides, really. I think what we deliver relies on extremely strong data stewardship. And to me, I think it's in the profile, I don't think, technical solution should come after the problem, and that is a real that is a real problem, and I think we would look to use electronic data cataloging, whereby where it's come from, who's provided the data, what's it being used for, what are the governance arrangements. We would look to put that into an electronic format, so that it is so that it's very carefully curated. And I think, as I said, it's that stewardship is so important, about provenance of the data, about where it's come, the lineage of the data, and the linkage. One thing that we have massive challenges with is linkage at the moment, and to be able to link that data in a more effective way would pay some real dividends. Would pay some real dividends for us. I think also that product also allows people, there are tools there that allow people to see what's in the data mart effectively. So we'd like to build like an Amazon style shopping interface there, where people can see all the data sets that are in there, see a sample of the data and add it to their basket, and then based on based on their access, either get that data immediately. If it is immediate, look at the conditions on which that data can be, shows how the data can be used, but also how it can, whether it should be anonymized or not. And if they haven't got the access, to federate those requests up to data stewards to look at those requests more carefully. I think I'm saying there's a technological solution to this problem, but I think we need an electronic solution to that area in order to effectively support that problem.
Thank you, George. That's really helpful insight. I want to come to Stephen now. Stephen, the focus of this conversation is quite wide. Actually, we've widened it out, but we wanted to focus in specifically on patients, digital communication, and patient-generated data. In terms of digital services for patients and public, what do you see as being some of the biggest challenges to taking this work forward?
Yeah, thanks, Sally. In some ways, I'm the wrong person to ask about the challenges, because I'm eternally optimistic about this space. I'm very excited about the next few months, in fact, in terms of the progress we're going to see and be able to make in this space. But trying to turn that into challenges, one of them is definitely the speed, the expectations of the members of the public, and what we're actually able to do is it's putting pressure on us to make rapid changes and progress in this space, and that is a challenge, which kind of feeds into my second challenge, really, which I kind of typified by talking about marching in step. So in my presentation, I talked about the scale of the patient-facing digital services environment. It's huge. Many people are working in that space. And I guess we've got a choice. We can either be like a flock of murmurating birds that all fly gracefully around the sky in perfect formation, or we can be like a load of cats that run around in lots of different directions. And I guess I'm advocating something more like the birds flying together. So everyone's kind of doing their own thing, but actually the total picture is a cohesive whole. And that's a challenge, because it's just not in our nature to kind of behave that way. It requires a lot of communication, a lot of pictures like the ones that George has been showing, to get everybody to see where their part of the jigsaw kind of fits in the overall picture. So that is a challenge, and it's a challenge that requires good and consistent terminology. So when we talk about something, we all know what we're talking about. So that's a challenge. And then the third area of challenge, I think, and it's something that's embodied within the DSPP programme, and that is the continuous need to ask the user and speak to service users. And it's something that we're not particularly good at, but is absolutely built into the models that we're using going forwards. And I find particularly interesting, because when you talk about the NHS and the health and care environment, we're all service users, so we've all got a pretty good experience of using the service, and and yet we're not particularly good at listening to the users in the design of that service. And I think when it comes to digital services, we need to change that, and that is a challenge. We need to design services from a user perspective. And the reason why I sort of believe that really strongly is that actually the previous questions that we just had and the answers we've just had, yes, I agree with the answers, but I would have also added that we again need to turn it on its head. So when we talk about information governance and access to data, if you think of every single transaction with an individual that the health and care environment makes, and if you think about that transaction as adding on the end of it, just as the patient walks out of the door, an electronic equivalent of handing the record of that transaction to that individual, and they take it with them, the next time that person presents, whether it's on the telephone or making an appointment or walking into GP surgery, if they've got that electronic record conceptually with them, they hand it over, and that creates the join. It gives the information governance solution, it gives the joining up of the records, it makes the linkages that George is talking about. If you conceptually give a structured record of the activity to the individual, you fix so many of the problems that we're talking about. So flipping it on its head and building the solutions around the service user, I think, are the answers to those challenges.
Thank you, Stephen. So there's some common themes coming through here again, the importance of communication in every aspect of this work, and transparency and communication with the patients and the wider public, but also with professionals, because we know as we're designing patient-facing technology that we also need to consider how that interaction plays out with clinical processes, don't we, in terms of what clinical teams are doing, so that lands and it gets properly utilised. So some really important themes coming through there. I want to ask probably the last question to Rachel. So we've heard a lot about the aspirations and the challenges in this work. What do we have in terms of early adopters and early examples of success in this field?
Yeah, so we're already doing some really good stuff in this area, to be honest. So it's we're working towards doing more, but we do have some examples, particularly around the PROMS data. So we're making that more usable within our data warehouse and bringing more PROMS data sets within the data warehouse. We've also done some work in terms of PROMS visualisations in the Welsh Clinical Portal, showing patient responses over time. We've released lung cancer, heart failure's next, and we've got hip and knee in development, and there's more to come. We've also got lymphedema PROMS data acquisition for the lymphedema PROMS dashboard. Lymphedema dashboard. So a lot of work in that area where we're bringing those types of data sets in. And again, just building on the previous discussions around the curation of data and the data linkage. And I mentioned previously as well, we've got 30 years worth of healthcare data within our data warehouse. So we are, data experts in terms of bringing this data together and making some sense of it and making the pathway more visible and really making, adding some value to what we already hold. So I think we're in a good position, and we've got some really good examples of where we've started to make this a reality, actually. So it is quite exciting what's on the horizon, but some really good work so far.
Thank you, Rachel. And so 2 points just to sum up at the end. One is a shameless plug for the Bringing Data to Life session tomorrow. We've seen lots of condition-specific examples of good data usage today, and there'll be some more throughout the week. But the Bringing Data to Life session tomorrow really illustrates what the approach is to this, and how we can start to use data to really improve outcomes and services in the coming months. Really important anyway, but as we move out of the pandemic, of absolutely critical importance. And the last point I think Stephen touched on, which is about integration of care and seamless movement of the information to support safe patient care, which patients would very reasonably expect. And integrating care has been something we've really struggled to do over the last 20 or 30 years in healthcare, and giving people ownership of their health information in the way that Stephen has just described is a way of patients and the public starting to integrate us and taking on that role, which in many ways is a very reliable, probably the most reliable way to do that. So I think there's huge opportunities there to improve communication between patients and their healthcare providers. I'd like to take the opportunity to thank the panel for their expert views today. It's been a really useful conversation, and I think useful to talk about all elements of this work together in one place. And I'd like to thank also the Value in Health team for organising it and running the session as ever. Thank you very much for joining us today. Thank you for your questions, and we will see you again shortly.